Please do stay and join us for the next session. It's a wonderful session, Emerging Voices in Endocrinology. We are having a young endocrinologist from all over the country. For this, we are having a panelist, Dr. Uniba Saeed, consultant endocrinologist in VP Punjab, Dr. Sarwar Malik, consultant endocrinologist, CD Hospital. We would like to start our this session without any further delay. I would like the panelists to kindly proceed with the sessions.
Bismillahirrahmanirrahim. Thank you very much to organizing committee and scientific committee for your kind invitation and for arranging a truly wonderful 11th Midsummer Endocrine updates filled with a rich scientific content. As we move into the last session of the last day, we are privileged to have 4 outstanding speakers. Without further delay, I would like to invite first speaker, Dr. Shoaib Khan. Shoaib will be talking about feeding nerves. What is the evidence base regarding supplements, regarding diabetic neuropathy? Please welcome to Dr. Shoaib Khan.
Assalamu alaikum. Thank you, Pakistan Endocrine Society, and thank you to all audience who are still sitting here, and thank you to the scientific committee for choosing such a wonderful topic, which is a burning problem of diabetes, a burning problem of burning feet. Hello? Hello? Acha. So this is a burning problem of burning feet. So we'll make a start. So feeding. So the topic basically is that in diabetic neuropathy, do supplements help? What do we do with supplements? Do we give them supplements? Do we check it and then give, or do we give it empirically? So I'll try to summarize the evidence and try and come up with a plan for these patients. So we have a lady, she's 50-year-old, and she has got type 2 diabetes mellitus for the last 15 years. She's taking metformin, sitagliptin, and omeprazole, and she's got burning feet. And all the diabetologists, endocrinologists, medical specialists, physicians, they will all agree that this is a common patient. You know, if you're doing a diabetes clinic, this is a common problem you will see. So what do we do? So obviously you'll try to control her diabetes, we'll give lifestyle changes, you know, we'll maybe give her some duloxetine or gabapentin. But the question for today is, do we give her vitamin B12 supplementation? So can we have a show of hands? Who here will give her vitamin B12 supplementations? Okay. Who will not give vitamin B12 supplementation? Okay, so we have large number of people who will give. We have a small number who will not give, and we have an even larger number who don't know or who are undecided like me. So next question, who will give vitamin D supplementation to her? Please raise your hand. Okay, decent number. Who will not give vitamin D supplementation? Again, decent number. And again, a big number who are still undecided like me. Okay. So objective today, we'll try to summarize the evidence around B12 and vitamin D, although there are some other supplements that are being discussed in literature as well, but in a 20-minute presentation, it's difficult to, you know, expand too much. So we'll try and focus on B12 mainly, and then a little bit of vitamin D. So diabetic neuropathy in diabetes, you know, there's hyperglycemia, vascular insult, metabolic problems, and then the nerves start to malfunction. There is mainly the peripheral neuropathy, but there's also focal neuropathies, autonomic neuropathy, proximal neuropathy, you know, but main problem is the peripheral neuropathy. Very common. You would agree to that, yeah? So the diabetes patients that come to your clinic, almost half of them have got, you know, diabetic neuropathy. If they haven't got it today, they'll probably get it some point later in their life. Risks of diabetic neuropathy. So duration of diabetes, as it's, you know, longer duration, more risk, you know, not good control, another risk. Old, age, another risk. And then hypertension, there's another risk. Cholesterol. So these are some of the risks that we know increase the risk of diabetic neuropathy. Supplements of interest, so mainly B12, vitamin D. There are some discussions about acetyl and carnitine and alpha-lipoic acid, but as I said, we'll mainly focus on the B12 and vitamin D. Okay. So B12 is a micronutrient. You can't synthesize it in your body. You have to eat it. It's mainly in meat, chicken, fish, and dairy products. You develop a B12 deficiency if you're not eating enough or if you're not absorbing enough. So what is the evidence around B12 deficiency or B12 and diabetic neuropathy? So first question always comes to your mind is there any association of B12 and diabetic neuropathy? So yes, there is very good evidence, 3.67 times more likely that a patient with diabetic neuropathy will have B12 deficiency. So it is quite closely associated. This is proven in research. Treating B12 deficiency improves diabetic neuropathy. If you treat someone with diabetic, vitamin B12 deficiency, does it improve neuropathy? So yes, there is very good evidence. For example, this trial that I found was the strongest 1-year randomized double-blind placebo-controlled trial. So these are patients who have proven B12 deficiency. So they've done a blood test and vitamin B12 is low. They have diabetic neuropathy. Now they've given them B12. And when they did, their symptoms improved. So yes, so if you have a deficiency and you've proven it, you have to replace it and you have to give them B12. But then what about empirical treatment? How often do you check B12 in a neuropathy patient? No, not much. So then the question is, some people do, yeah. But in my experience, I work in a district headquarter hospital in a small city, and my patients, 95% of them are low socioeconomic status. So I don't see vitamin B12 checked that much. So then the real question is that what do we do with those patients when we are not checking? Do we have to check? So then, or do we treat them empirically? So I found some meta-analysis and review articles on that. And the evidence was, and they've said that yes, it does improve diabetic neuropathy in treating empirically. But then there's some questions around that. Firstly, these are low quality studies. 80% of these studies have high risk of bias, and small number of patients. And secondly, there's lots of heterogeneity. These studies, if they had, for example, in one study there was 8 or 9 hour trials, but many of them, or few of them at least, were the patients who had been checked and they had a B12 deficiency and they were treated and they had shown improvement. So the trial did not really make the difference between empirical treatment and treating someone with deficiency. So I would say that this evidence was not solid in empirical treatment. But then the question comes is how prevalent is B12 deficiency? That might help us decide about this empirical question, right? If it is extremely common, if everyone's got B12 deficiency, then maybe we don't need to check. Or if very few have it, then maybe we need to check. So these are some of the studies from Pakistan. So in general population, 8 to 25% have B12 deficiency. In those who have diabetes, 30 to 40%. And these, the higher end studies are those who are on metformin. So we know that people who are on metformin, they are more likely to develop B12 deficiency. And everyone who's got type 2 diabetes, they probably are or should be on metformin for a long time. So then the prevalence goes high. And then there was some studies specifically about looking at patients with diabetic neuropathy, and then that percentage goes to even 50%, 35 to 50%. So, and the low-end studies, you're saying 1 in 3, every third patient who's coming with diabetic neuropathy in your clinic has got deficiency, or 1 in 2, in some high-end studies. So this is the prevalence. In summary, regarding vitamin B12, We can see that in proven deficiency, yes, you have to give them B12. In unproven deficiency, it may improve. You know, I don't think we can be conclusive about it. And then the other point that I think comes in it is that every 1 in 3 or 1 in 2 of your patients will have deficiency, whether you check it or not. This is what research tells us. So then we can go to vitamin D. So vitamin D again, vitamin D deficiency is associated with diabetic neuropathy. That has been established in research. Replacing vitamin D in deficient patients does improve diabetic neuropathy. That is also proven in research. And then vitamin D deficient, giving vitamin D to people who don't have deficiency does not improve their diabetic neuropathy. That is also proven in research. So, and what is the prevalence of vitamin D deficiency in Pakistan? That's again the same question about vitamin B12 as well. So general population very high, 60 to 85%. Diabetics, 80 to 90%. And those who have diabetics with diabetic neuropathy, 90 to 95%. So almost everyone who does not take supplements is vitamin D deficient. So in summary regarding vitamin D, improving vitamin D in deficient patients improves diabetic neuropathy. In non-deficient, it does not improve. And everyone who doesn't take vitamin D supplements is deficient. So the guidelines. So this was the evidence, and if you look at the guidelines, you know, international guidelines or our own Pakistan Endocrine Society guidelines, this is what they say. They say that you should check for B12 and vitamin D, and if they are low, you should treat it. So they don't say that give it to everyone. They say that you should check it, which seems logical because yes, if you are deficient, yes, you should treat it. But if you're not deficient, you're unlikely to improve from it. But then the Pakistani context, which I've alluded to before, you know, our patients may not have, you know, the resources to get checked vitamin B12. It is extremely common. You know, B12 deficiency and vitamin D deficiency is very common. So, you know, maybe we need to rethink it, or we need to think about the guidelines regarding my specific patient or my specific, you know, if I'm someone, I'm an endocrinologist working in, if I'm Dr. Umar Yusuf Raja working in Shifa, you know, then maybe my thinking will be slightly different. Or if I am Dr. Shoaib working in, you know, Mirpur, DHQ, maybe I'm different, or, you know, I don't know. This is something you can think about. So we can come back to our lady. This is your everyday patient in your diabetes clinic who's come with burning feet, you know, and she's on these medications. So after this summary of the evidence, let's have another, you know, show of hands. Who will give her vitamin B12 supplementation? Okay. I don't know if it's changed or not. Who will not give vitamin B12 supplementation to her? Okay, so there's one more person who's not going to give. Before there was only 2, now there's 3. And who is still undecided? Or who will think about the context? Okay, let's think about vitamin D. Who will give her vitamin D supplementation? Again, you know, quite a few hands. Who will not give vitamin D? Okay, so there's not many who will not give. Almost everyone will give. So, you know, there's some discussion points that I'm leaving you with. By the way, this is you can give feedback for this presentation. So if you can get your cameras, you can have this QR code. And if you want, you can give me feedback on that. So this is the discussion points. You know, do you check for everyone? Or who do you check? Okay. Empirical treatment, do you just give it to everyone? You know, do you assume that it's very common and do you give it to everyone? What is the cost? What is the cost of doing a test? What is the cost of giving them empirically to everyone? You know, what is the pill burden? You know, lots of your patients have diabetes and hypertension and dyspepsia, and you know, maybe they are depressed as well. You know, ischemic heart disease. How many tablets are you going to give them? You know, this is something you're going to see. Maybe if you start giving them these vitamins, they're not going to take the diabetes medicine. So this is where I end my presentation. I hope I have, you know, given you some food for thought. So thank you very much.
Thank you so much, Dr. Shoaib, for touching a very important topic, and I think these are the points that we do think about daily. Now, before I invite our next speaker, I'll request you all, if you have any question, please make use of this QR code or the Slido that we have, and you can ask questions from us. Our next speaker is Dr. Maliha. Dr. Maliha is consultant endocrinologist, well known in the PES family. She's presently working in Lahore General Hospital, and she'll be talking about subclinical hypothyroidism and fertility. What is the evidence? Thank you, Dr. Maliha.
Assalamu alaikum everyone. So today we'll talk about this important topic. Okay, so we have a 32-year-old woman who's trying to conceive since the past 7 years. She conceived once but had a missed abortion. Her TSH is 4.2. Her BMI is 27. Her BP is 110/70. She went to the gynecologist who did a workup, and recently she also underwent a diagnostic laparoscopy including dye test for tubal patency. It is normal. So how will you proceed in this patient? What should we do further? Okay. TSH is 4.2, free T4, fine, that is normal? Okay, fine. So let's go through and the presentation. So our topic is subclinical hypothyroidism and fertility, and what evidence we have from literature. So subclinical hypothyroidism, what is subclinical hypothyroidism? As we know, this is elevated TSH with normal thyroid hormones. Usually you will see in your practice that many people are undiagnosed, and as a result they suffer a lot of health consequences, especially infertility and effects on reproductive health. The prevalence varies. It's around 4 to 10% of the population. So what are the causes of subclinical hypothyroidism? Most commonly chronic autoimmune thyroiditis, Hashimoto's, then other types of thyroiditis, thyroid injury, for example after partial thyroidectomy or so. We should be aware of the drugs causing impaired thyroid function, some of them very commonly used. Iodine and iodine-containing medications, amiodarone, radiographic contrast agents, lithium in psychiatric patients, cytokines, aminoglutathione, ethinomide, which is one of the anti-tuberculous, sulfonamides, and sulfonylureas. It might be a result of inadequate replacement in a patient with overt hypothyroidism. Commonly used drugs, not drugs actually, supplements, iron, calcium carbonate, even fiber, these can also lead to this. Increased T4 clearance with some drugs, phenytoin, carbamazepine, phenobarbital, important in epileptics. In malabsorption patients, thyroid infiltration, central hypothyroidism, some toxic substances, industrial and environmental, and gene mutations. So what is the role of thyroid hormones in fertility? Thyroid hormones play a crucial role, including it has effects on the ovarian function, ovulation, menstrual cycles, and fertility. Evidence from American Thyroid Association shows that subclinical hypothyroidism negatively impacts fertility rates. It is associated also with polycystic ovarian syndrome and premature insufficiency. Of course, infertility is a major concern. So just look at the hypothalamic pituitary thyroid axis. So as we know, we have a pointer as well. Yeah, so the TRH released from the hypothalamus causes release of TSH, which affects the thyroid, causing release of T4, T3, and then T4 is converted to the active form with deiodinase 1 and 2, and then the D3 converts it to reverse T3. So it is this T3 which then causes the gene transcription and then causes the cellular effects. So what are the central effects? That's what we're talking about. We will see that there are central effects starting from the hypothalamus, and the central neurons which stimulate the pulsatile release of GnRH from GnRH neurons. These are affected by the thyroid hormones themselves. Then with the energy hormones such as insulin-like growth factor, and leptin, with CRH and glucocorticoids as well, and with TRH. TRH has a negative effect, has a positive effect on prolactin release. So the thyroid hormones, TRH, TSH, T3, T4, we can see this slide, they have effects at all levels. These affect the hypothalamus. In the release of GnRH, they have an effect. They directly affect the ovaries, the ovarian function, and the ovarian volume and follicular count. They affect the endometrium, including the endometrial proliferation. They're even important in pregnancy, including the implantation. And they are effective in trophoblastic proliferation. That is why with subclinical, even with, we're not talking about overt here, but even with subclinical hypothyroidism, miscarriages, the incidence increases. So there are effects at all levels with a lot of negative feedbacks going on. Now this TRH has a positive effect on, it causes a rise in prolactin. So the thyroid hormones have a negative effect on TRH here. And obviously we know we need a normal prolactin for normal gonadotrophins. So it has effect on all levels. So now from, I've quoted few studies. So in one study, it was the prevalence of subclinical hypothyroidism was seen in 244 women with infertility. And 244 women with infertility were evaluated. Subclinical hypothyroidism was seen in 13.9% as compared to 3.9% of the control women. So 10% higher infertility with subclinical hypothyroid. In a meta-analysis of 4 studies, the presence of thyroid autoimmunity prior to conception increased the rate of unexplained subfertility. In men, subclinical hypothyroidism is associated with increased sperm DNA fragmentation, and there is increased pregnancy loss in women with subclinical hypothyroidism and in euthyroid women with TPO antibody positivity. So risks of untreated hypothyroidism in pregnancy are multiple, including miscarriages, preterm birth, low birth weight, developmental delays, cognitive decline in the child, as well as placental abruption. Now the screening guidelines of American Thyroid Association. The American Thyroid Association recommends screening for subclinical hypothyroidism in women planning a pregnancy, especially those with a history of infertility or recurrent miscarriages. And of course, early detection is crucial to save the patient from a lot of problems throughout many years of infertility. So most patients with subclinical hypothyroidism are due to Hashimoto's thyroiditis. Anti-TPO antibodies are very important because they predict the likelihood of progression to overt hypothyroidism. So they are tested usually, but anti-thyroglobulin antibodies can be tested, but they are not that specific. Besides, they do not predict the progression. So not very useful. In pregnancy, okay, now this should be a question before. Will you screen every patient, every pregnant woman for thyroid insufficiency? Yeah, every pregnant woman for thyroid insufficiency. Okay, so according to the guidelines, universal screening of asymptomatic pregnant women for thyroid dysfunction during the first trimester of pregnancy is controversial. So far, a targeted approach is recommended. Specific patients need to be tested. Those living in an area of moderate to severe iodine deficiency, those with symptoms of hypothyroidism, those with a family or personal history of thyroid disease, patient with a history of anti-TPO positive antibodies, those with a goiter, age greater than 30 years, type 1 diabetes, head and neck irradiation, history of recurrent miscarriages or preterm delivery, multiple prior pregnancies, class 3 obesity, infertility, prior thyroid surgery, and of course, if patient is using any of those medications we already talked about, especially amiodarone, lithium, or the patient recently underwent in the past few months some iodinated contrast agent study. So diagnosis is simple. You do the TSH, that's just the diagnosis. TSH and free T4, TSH is normal and the free TSH is raised and the free T4 is normal. So in pregnancy, in women who meet the case criteria, we will test the patient for hypothyroidism again with TSH and free T4 and TPO antibodies. Now how do we proceed? If TSH is above 2.5, we measure the TPO antibodies. And if TSH is above the trimester specific upper limit of normal greater than 4, we also measure the free T4. So you know that in pregnancy we use the trimester specific ranges or for the specific population if available. And if not available, then we have certain cutoffs, which I will just show you. So these are the cutoffs. Like in the first trimester, 2.5. This is the upper limit of TSH. Second, 3, and third also 3. Some say 3.5. If you have the population specific ranges, that's great. So now considerations for treatment. Whom will you treat? Whom will you not treat? Will you treat everyone with a TSH greater than 2.5? Okay. So let's go through this. So this is based on TSH, patient's age, the fertility goals, and individualization of treatment is important in all diseases, including thyroid, subclinical hypothyroidism, just as in diabetes and other diseases. You have to keep the context if the patient is having recurrent miscarriages, if the patient has a long history of infertility, you have to be more careful there. So these are the treatment recommendations as per American Thyroid Association guidelines. So if the TSH is greater than 4 with TPO antibody positive, treatment is recommended. There's no second thought. If it is greater than 2.5, again with TPO antibodies, treatment should be considered. If it is greater than 4, even without TPO antibodies, you should treat. Now between 2.5 to 4, this is debatable according to the patient, and less than 2.5 is not recommended. So this is a chart. Perhaps we can use the pointer here. So in a pregnant patient, even in a patient who is trying to conceive, in both cases, and with infertility, what is the initial TSH? If it is greater than 4, you will treat. Now if we go through this, is the free T4 low? Yes, obviously we'll treat with the full dose, 1.6 microgram per kg. And if it is free T4 is normal, then you will start with a low dose. Now if the TSH is between 2.6 to 4, then check the TPO antibodies. They're important here. If they are positive with a prior history of recurrent miscarriages, it should be treated. And if no history of recurrent miscarriages, then again individualization of treatment according to the scenario of your patient. If anti-TPO antibodies are negative and TSH is between 2.6 to 4, then generally not recommended. And then less than 2.5, it is not recommended. So these are the doses. The standard dose of overt hypothyroidism, 1.6 microgram, and then in subclinical, 1 microgram. Now, what are the key considerations for fertility? Just now, the key messages. I made a short presentation since we're coming towards the end of the session. So thyroid hormone replacement can improve ovulation, reduce miscarriages, and increase the likelihood of live births. Optimal TSH level of 2.5 or lower is generally considered optimal before and during pregnancy. Individualized management is important in the management of every patient, including the presence of TPO antibodies, the severity of hypothyroidism, and the woman's overall health. Preconception counseling is essential for women with hypothyroidism because preconception counseling from their healthcare provider to discuss the treatment options and optimize the levels before attempting pregnancy. Early intervention will improve fertility rates as well as outcomes and reduce the risks during pregnancy. Now monitoring and follow-up, how do you monitor? Now we're talking about a patient with subclinical hypothyroid. So regular monitoring is essential. particularly if the patient is seeking fertility. You do your initial workup, and then at least every 6 months you monitor, and if it's normal, then you can extend it to 1 yearly. But if there's any change in symptoms or you have started treatment, then earlier monitoring, 4 to 6 weeks after you do the change. During pregnancy, the monitoring is every 4 weeks in the first trimester, and thereafter at least once in each trimester. The goal is to, if we take an average goal, is to maintain the TSH approximately less than 2.5. Then reassess during pregnancy, and if it rises above the trimester-specific ranges, then you start treatment. What about assisted reproductive technologies? Screening for subclinical hypothyroidism is obviously very, very important here, and it's always done, and it's always treated, because as we saw before, thyroid hormones have effect on every level of the hypothalamic pituitary gonadal axis, starting from the central neurons, which affect the release of gonadotrophins directly on the hypothalamus, on the pituitary, on the ovaries, on the uterus, the thyroid binding globulins as well. So this is very important, this, and what can we think about the future? So we need more research to focus on the genomic techniques and the genomic studies. What is the relationship between subclinical hypothyroidism and fertility at the genomic level? Additionally, we need to assess the outcomes and to optimize management strategies to further address this problem, because even now you'll be seeing in your clinics patient coming with a long history of infertility, and it's just thyroid, subclinical hypothyroid. And when you treat it, the patient is pregnant in the last 6 months. Dr. Tahir has a very good collection of cases, and myself, but I couldn't add it now. So this we have seen in practice. The patient is so happy. Like, I have a patient currently in Sialkot, and she was infertile for 8 years. She was obese as well, not diabetic, and menses were irregular. And then we did the workup, and it was subclinical hypothyroid, and now, mashallah, she's pregnant the second time. She had her first baby 2 years back, and now she's pregnant again. And the babies are fine also, alhamdulillah. And similarly, all of you must have experiences. So obviously, if, we are always learning, and we're always in the stream of education and awareness, and we need to continue our education and research regarding subclinical hypothyroidism, fertility, and all other diseases, so that we can help people in a better way. Thank you very much.
Thank you, Dr. Madhya, for a detailed presentation on subclinical hypothyroidism and infertility. Our next speaker is Dr. Adnan Zahid. Dr. Adnan Zahid is a consultant endocrinologist and clinical lead at Beria Hospital, Beria International Hospital, Islamabad. He is talking about the hidden cost of steroid therapy, iatrogenic Cushing, a preventable endocrine burden. Please join us in welcoming Dr. Adnan Zahid.
Bismillah ar-Rahman ar-Rahim. Good morning, and thank you for having me. We are running in the ending session of this great academic forum, and the topic that I'm going to discuss today is the iatrogenic Cushing, which is a preventable endocrine burden. So, if we talk about this iatrogenic Cushing, so we are dealing with the steroids. These steroids, these medication, these steroids can be a blessing for someone, but they can be proven to be a curse if they are used unchecked. So we'll talk about the same topic in detail. This is the overview of my presentation. We'll talk about the what is the iatrogenic Cushing, the metabolic effects of the steroids, what is the prevalence. We'll go through the local and the global data. In this context, what could be the complication of the steroid excess, HPA suppression, and then comes the other part of the talk, that is the adrenal insufficiency. What are the risks? What should be the rationale approach to taper the steroids, and how do we monitor the disease process, and what is the importance of the steroid sparing strategies, and in the end, what is the importance of the public awareness. So, in the simplified word, it refers to the hypercortisolism resulting from the exogenous glucocorticoid administration for any of the indication. And it has a widespread prevalence, and so it is very important to know, to understand when to use it, how to taper it down, and you should discuss with the specialty, with your colleagues, with the patients regarding the risk and the benefits. In the medicine term, we commonly go through this term, the risk and the benefit ratio. So it truly applies here what could be the risk and what are the benefits of these steroids. Some of the clinical uses of steroids, as you all know that steroids, they have a lot of indications in different specialities. If you talk about the endocrine, in the Addison's disease, in the Graves' orbitopathy, in the dermatological specialities, GI, liver, but the main, the focus, like most of the cases, if you talk about the iatrogenic Cushingite, they come from mainly the two specialities, the rheumatology, and the pulmonology. So, what are the metabolic effects of the steroids? So, in the upper part, you can see what could be the therapeutic effects of the steroids. How do they act? They basically have an immune modulatory role and the anti-inflammatory effects, and that leads to the decrease in the pain, the swelling, the stiffness, and decrease in the it enables the patient to move around and improves the quality of life. If we talk about the rheumatological indications, then they have the effects on the joints and in different systems. But if they are used for a longer period of time, they can prone to the many complications, to the risk of infections. They can cause the myopathies and affect the metabolism. On the CNS, they can cause the psychosis, the depression. Initially, the patient can feel euphoric, but in the longer run, the patient can have different psychotic manifestations. They leads to the weight gain, the fluid retention, the Cushing syndrome, impaired glucose metabolism, and can cause to the skin thinning and can affect deleteriously on the cardiovascular health as well. This is the basis of the whole endocrine system. As you all know that this is how the endocrine system, the different hormones, they are under this HP axis. Usually what happens from the hypothalamus, there is a release of the CRH, and it acts on the ACTH, on the anterior pituitary, leads to the secretion of the ACTH. This ACTH, it acts on the adrenal and release to the secretion of the cortisol along with the steroids. Then there are stressors, like in the normal stress, what happens is like there is activation of the CRH, and then there is the release of the cortisol. Along with that, we in cases of trauma or hypoglycemia and hypertension. So again, if the patient's in stress, then it can also leads to this. It usually leads to the secretion of the cortisol. We talk about the causes of the Cushing syndrome. It includes the ACH-dependent and ACH-independent causes. I'm not going into the details. Today we'll be discussing the ACH-independent causes, that is the iatrogenic Cushing by the use of the DEXA and other steroids. So the iatrogenic Cushing's, the irrational use in the daily life for the common diseases, as you all know that in Pakistan we are living like we are the third world country, and more than 50% of the population living below the poverty line. We don't have a very robust, very good primary healthcare system. What happens that mostly patients, they have these pains, they have these, any of these conditions, they have, they go to the local GP and to their local doctors, and it's a strong word, but the quacks. Because if you don't know like what you are dealing with, you are harming your patient, then I mean it has not been done, it should not be done, but again that's the concern of the health regulatory authority. But that's the one of the main reason why we have a lot of disease burden for this condition, because every now and then पेशेंट को दर्द होता है, ही और शी विजिट्स इस लोकल डॉक्टर, और वो क्या करता है एक इंजेक्शन आपका लगा देता है पेशेंट को, वक्ती तौर पे ही और शी फील्स बेटर, उसको अच्छा लगता है, और फिर वो एक ट्रस्ट पेशेंट का बनने लग जाता है, और फिर वो आगे पीछे लोगों में एक वो होता है, और फिर वो जो मोहल्ले का डॉक्टर है फिर वो जिस तरह से लाइक कर रहा होता है, तो अगेन इट over a period of time, it increasing the number of the patients with the iatrogenic Cushing white, use of Hakimi and the over-the-counter medication with a high steroid dose. So I've gone through the local and the global data. We don't have much studies, but this was one of the studies that was being done about 2 decades back in one of the rheumatological center in Islamabad, and it has found that 42% of the patient presenting with the joint pain, they were using the steroids, often prescribed for the condition, unresponsive to the therapy. Like वो steroids ले रहे थे, but again उनकी शायद indications नहीं थी और वो respond नहीं कर रहे थे, but they were keep taking the steroids. So this is the data from the capital of Pakistan. So you can just imagine like कि जो छोटे शहर हैं या दूसरे जो suburbs हैं, कितनी common है ये practice to go for these shortcuts, like just have this injection of steroids. और जो post COVID era है उसके बाद now recently we have this COVID variant where the patient have this chronic cough, this the sinusitis. Every now and then the patient keep having the cycles of these steroids. Along with that, this is a study from Karachi, from one of the dermatological unit, and around 83% of the individual, they were using the fairness creams containing the steroids, and they developed acne, and it highlights the misuse of by different doctors, by the so-called dermatologists of these steroids. Talking about the international data, so again, there's a high global prevalence as well. The WHO estimates that around 50% of the medications are prescribed or used inappropriately, with steroids being a significant contributor. सस्ते होते हैं, easily मिल जाते हैं, especially if we talk about the countries where the health systems are not been scrutinized, are not been regulated. So कोई भी आप जाते हैं वो इंजेक्शंस हो जाते हैं, आपको टैबलेट्स दे देते हैं और उससे पेशेंट बेहतर लगता है, और एवरी नाउ एंड देन जब उसको लाइक ही और शी कीप्स टेकिंग दैट. अगेन cosmetic use, a lot of patients being using these creams containing the steroids. One of the in sports medicine, if you talk about the athletic abuse, the study from the Bosnia found that around 55% of the male athletes under 35 who misused anabolic steroids, they ending up in developing the hypertension, the hyperlipidemias, increasing the risk of the cardiovascular deaths and cardiovascular diseases. Another specialty where the use is quite common, the gastro. So again, a lot of patients with IBD, they had presented with the complications with those steroids. So important factors are the overprescription in the rheuma, the pulmo, and over-the-counter, along with the Hakimi medications, and the absence of the steroid-sparing strategies. So if we give the patients, if we give patients the steroids under check versus the inadvertent steroid use, so we can avoid a lot of these complications. So these are the clinical features. Here you can see the moon phase, the stria, the acne, the gynecomastia. So, and these are the images from the real clinics, from the real life. These are the patients presenting in the tertiary care hospital, the facial plethora along with the abdominal stria. So these steroids, so now we have covered the one part of this disease, that is the Cushing's features. Now this is more a dual sort of a disease process we are dealing with. Like एक तरफ तो excess हो गई जिससे मसले हो गए, अब उस excess के बाद अब deficiency को हमने treat करना है. So it's very unfortunate that first we cause the disease, then we treating it. So the tertiary adrenal insufficiency, again, the HPA axis, as you all know that when the patients keep taking the exogenous steroids, what it does, it suppresses the CRH, the ACTH, causing the secondary and the tertiary adrenal insufficiency, and through the negative feedback, it leads to the suppression, the decreased secretion of the cortisol, along with the DHEAS levels. Usually the aldosterone is not affected in the secondary or the tertiary insufficiency as compared to the primary adrenal insufficiency, because it is being activated by the RAS system. So what are the clinical features? How you can differentiate between the primary and the secondary or the tertiary adrenal insufficiency? In the primary, the cause within the adrenal gland. The ACTH levels in the primary, they are elevated. In the secondary or the tertiary, they are low. The cortisol levels both are low, low in both primary and the secondary. The aldosterone is low in the primary insufficiency, while it usually stays normal because the RAS is intact in secondary or the tertiary insufficiency. Electrolytes, parameters, in the primary we have the low sodium along with the high potassium, but in secondary we usually have the low sodium along with the maybe normal potassium levels. Skin pigmentation is one of the cardinal feature of the primary adrenal insufficiency, and is usually absent in the secondary or tertiary. Hypertension, common and more severe in the primary causes as compared to the secondary or the tertiary. The other features, the salt craving, the weight loss, fatigue, and the response to the ACH test. In the primary, there is no rise in cortisol, but in secondary or the tertiary, there can be a gradual or the blunted rise in secondary or the tertiary adrenal insufficiency. So along with the steroids, there are certain other drugs which can lead to the adrenal insufficiency, and the most important is the monoclonal antibodies, which is a new kid on the block, and especially if being used for a longer time, they can also lead to the adrenal insufficiency. So a lot of patients, like we don't have many patients on the monoclonal antibodies in our part of the world, but because there are different reasons, the cost or the availability. But you should have in mind that patient taking these antibodies, monoclonal antibodies, can present with the adrenal insufficiency. So when to suspect the tertiary adrenal insufficiency, history taking is very important. Patient आएगा खुद बताएगा, let's say मुझे दमे का मसला है, जोड़ों में दर्द रहता है, and the moment the patient enter in your clinic, you can feel that. The patient with the typical Cushing-White features, usually you can see from the face, you can make a diagnosis on the spot. So his history of medication, especially for the chronic illnesses like the asthma, the chronic obstructive airway disease, the arthritis. These are the main diseases for which the patient usually take the steroids. The Cushing-White features, like you examine the patient, you take the history of the examining the patient, you see the patient have the Cushing-White features, just do the baseline low serum cortisol level. Obviously, the patient should not be on steroids when you use this baseline serum cortisol. And if it's low, most likely the patient is having this tertiary adrenal insufficiency. But at times, the patient can present with the subtle symptoms. Like history में बड़ी वेग सी history देगा कि ऐसा हकीमी तो नहीं लिया, लेकिन कभी कोई पुड़ी खा ली या इस तरह से कभी injections लगवा लिए. So you at time you need to dig in the history, and you need to आपने patient से उगलवाना होता है कि what medication he or she is taking, and the patient can have these presenting symptoms of unexplained weight gain, the skin changes with the thinning of the skin, the striae, the bruising, unexplained the osteoporosis, vertebral fractures, unexplained hypo or hyperglycemia. Patient कहेगा शुरू में मेरा शुगर रहता था high, फिर कुछ अरसे के बाद वो low रहने लग गया. And then the unexplained hyponatremia, which is very common, and especially we usually see in the inpatient department. Working in the tertiary care hospital, you used to get calls for the evaluation of the hyponatremia, and when the patient, you evaluate the patient, the cause can be this adrenal insufficiency. So what are the patients at the risk of the HPA axis suppression? If they are taking the prednisolone for more than, the dose more than 20 milligram for 3 weeks, prednisolone more than 5 milligram at night times for more than 2 weeks, because it can lead to the increased risk of suppression of the ACTH, and the patient having the clinical features of the Cushing-White. So, आपने पेशेंट को सस्पेक्ट किया, उसको आपने अब फर्दर उसके मैनेजमेंट की अगर हम बात करें, सो दे आर द टू एस्पेक्ट्स. वी नीड टू taper the dose, the steroids, and the tapering is of two types, like the therapeutic tapering and the endocrine tapering. So the general rules that glucocorticoids can be stopped without tapering if used less than 3 weeks, regardless of the dose. If the patient is on the long-term glucocorticoids therapy, taper if the underlying disease is controlled and the glucocorticoids no longer required. Do not taper if the disease is not controlled. Approach should be that we switch from the long-acting to the short-acting steroids like the hydrocortisone as physiological doses are approached, and tapering should follow the natural cortisol rhythms and along with the clinical monitoring. So what time usually it is required for the recovery of the HPA axis? So HPA axis, it usually can recover, take from like 9 weeks to 9 months, but in clinical practice, it can even extend 2 years. And so the tapering periods can be prolonged, and the adjustment during the tapering switch from the high potency to the low potency, like from DEXA to PRED to the hydrocortisone. And we should aim to reach the physiological doses, that is around the 5 milligram for the prednisolone and 15 to 20 milligram for the hydrocortisone. And they usually represent the normal physiological doses. So the therapeutic versus endocrine tapering. As far as therapeutic tapering is concerned, it should be done by the primary physician from any specialty, like from the rheumatology or from the pulmonology. And we should aim from reaching from supraphysiological to the physiological doses. Can taper fast if the disease is controlled, but that should be the decision from the primary from the end of the primary physician. You can discuss with the primary physician. We have this management approach, but first the disease needs to be controlled, and the goal is reach the physiological dose around 15 to 20 milligram hydrocortisone and 5 or less than 5 milligram of prednisolone. Once we reach to the point of the therapeutic tapering, कि आपके physician ने कह दिया ठीक है disease control में है और ये minimum dose of steroids पर है, now the ball is in your court. So then we should start and progress towards this endocrine tapering, and it starts once the physiological levels are reached. Slower tapering, it avoids the adrenal insufficiency, and at the same time we need to monitor and test for the adrenal insufficiency with the ACS stimulation test, and we need to monitor clinically for the AI symptoms, and we can discontinue the steroids completely when possible. So this is the same slide. I've discussed it, that we start from the therapeutic tapering, control the disease, reach the physiological dose from the high potency to the low potency, and once we reach the physiological dose and the patient switch to the oral hydrocortisone, then depending, we further decrease the dose of the hydrocortisone, reduce the dose by 5 milligram every 2 to 4 weeks, and it depends clinically on the patient, and then we need to look and monitor the morning cortisol for the recovery of the axis, and keep monitoring the HP axis with the serial monitoring. Now, for monitoring, we have this morning cortisol levels. Like, agar aapka patient, if he or she is taking 10 in the morning and 5 around in the afternoon, just skip the 5 milligram dose in the afternoon, and the next morning, just check the serum cortisol levels between 8 to 9 a.m. And if the levels are more than 10, it's reassuring, and it indicates usually the HP axis recovery, and the steroids can be tapered, can be stopped. If the morning cortisol is less than 5, but just few more minutes. So if the level are less than 5, we can continue the physiological dose and keep monitoring the patient with clinically along with the serial testing. Now, there comes a shady area when the levels are between 5 to 10 microgram per deciliter. You can assess the patient clinically, and you can go. You can also go for the ACH stimulation test. You can check for the reserves, and then decide accordingly whether the steroids can be stopped. Now, the second part, which is not usually done in the clinical practice, the levels of the DHES. We can check the DHES levels as well to look for the recovery of the HPXs. Why? Because two reasons. The DHES usually does not interfere with the assays, and the stability of the DHES is usually for 2 weeks. It's just like if you are checking the diabetic patient with the blood sugar, and or you do the HbA1c levels. So with the DHES levels, for the period of 2 weeks, you can check the adrenal reserves. And so once the patient reaches the physiological doses, we switch to the oral hydrocortisone, and we serially, like the DHES, we check the DHES values. You don't need to stop the steroids. You check the DHES values, because again we are basically assessing the recovery of the HPXs. As you all know that the CRH, the ACTH, it acts on the cortisol. It acts on the adrenal. There is a secretion of the cortisol along with the DHES levels. So when the levels are improving, it's also showing up that there is recovery of the HPXs. So if the DHES levels are seriously increasing, we can taper steroids rapidly and stop in few weeks. And if they're static or reducing, we calculate the DHES ratios. Why DHES ratios? Because DHES, the test, it can vary according to the age, as well as according to the gender. So we check the DHES ratios. How do we calculate that? We usually check the DHES level and divide by the low normal for that age. And if the ratio is less than 1, we continue the same dose, and again assess the patient clinically and with the serial monitoring. If the ratio is more than 1.8, it's very reassuring, likely showing the recovery of the HPXs, and we can stop and rapidly taper the steroid and stop it. But if the levels, the ratios remain between 1 to 1.8, then again it's a shady sort of area. We need to assess the patient clinically. We can check for the ACH stimulation test. It's the same. The ACH stimulation test, if the post-cortisol, if the cortisol level, if the post-ACTH stimulation less than 18 microgram per deciliter, HPA compromise, more than 18, usually it's normal. Last few slides. These are the last 2 slides. So, do the non-systemic glucocorticoids lead to the adrenal insufficiency as well? Yes. Yes, they do. And mainly, these are the inhaled steroids that can also lead to the adrenal insufficiency. Even though, I still remember a case while working in the PES endocrine setup. A mother came with her child, and she like around 2 years of age, and she has 1 year of age, and she has these Cushing-White features. And during the history digging, it comes out that she's been using the topical steroids cream for like more than 6 months for the diaper rash or for some sort of like a rash. So again, the topical steroids, they can also, but not commonly, and the inhaled steroids, they usually do. Because when you have these inhaled steroids, 10 to 60% deposited in the lungs, and about 40 to 90%, usually the patient can swallow them, especially with a poor technique. And it can be reduced by the use of the spacer devices, or if you ask the patient to rinse his or her mouth. And once they are swallowed, they are absorption from the gut, and then they is in the systemic circulation causing these features. So this last slide, the key takeaways: the iatrogenic Cushing-White is preventable and is a consequence of the excess steroid use. it's being caused by the widespread misuse and can have serious many complications. Recognition is very essential, early recognitions. We need to taper steroids cautiously and follow this patient clinically along with the cortisol levels. And even the non-systemic steroids can lead to the to this disease, and we need to promote this steroid sparing approaches, and public awareness is very common. And in the last, I think from the platform of this society, I think we need to discuss the matters. We need to highlight this this catastrophic problem, because it can be, as I said, that the steroids can be blessing, but they can be a curse for someone because of the complication it usually leads to. So for our the GPs from we can discuss with the health regulatory authorities. There should be a check and balance on the steroid use, because it's the same case as the use of the antibiotics. Like we've been using the antibiotic, it's easily available. So the same case with the steroids, every now and then, especially nowadays, because these new variants of these, the COVID variants with upper respiratory tract symptoms. Where I'm working, I've seen a lot of patients, because I have a very, the pulmonology use is very well established. So I've seen a lot of patients having this recurrent steroids intake every now and then.
Thank you, Dr. Zahid.
Thank
I
you.
couldn't agree more. And thank you for a great talk. And I think it was a high time to talk about this topic. So moving on with the last talk, and with the hall full, I think it speaks loads of the quality Pakistan Endocrine Society has maintained. I'll take this opportunity to request Dr. Rahmatullah, who is Senior Registrar in Bolan Medical College, and graciously joined us here for his talk. And this talk is also very important, and he'll be talking about New Graft, New Challenge, a spotlight on post-transplant diabetes, an evolving dilemma.
Assalamu alaikum. Bismillahir Rahmanir Rahim. Today the topic which I am going to discuss is post-transplant diabetes mellitus, and we will abbreviate it with as PTDM. Okay. Post-transplant diabetes mellitus, also known as NODAT, new onset diabetes after transplantation, is common in people undergoing solid organ transplantation and associated with adverse clinical outcome. The term NODAT has been replaced with PTDM because every diabetes is not new onset. The diabetes could be present before, and so because of this, the terminology was changed to PTDM. Evidence of PTDM, reported incidence of PTDM varies between 9 and 39 in the first year, and likely reflects the distinct patient demographics and immunosuppression practices. Beyond the first year, it is difficult to determine whether the incremental risk of developing PTDM is over and above the incremental risk of developing diabetes in general population. Incidence of PTDM is declining, possibly due to rationalized immunosuppression and reduced rejection. We will see, inshallah, in the future slide that if we use rationally, some of the immunosuppressants they are so much diabetogenic. So if we use them with the help of that, it will be decreasing. PTDM is associated with increased risk of mortality after transplantation, although this is not consistently reported. The association between PTDM and graft loss is unclear. There is association between PTDM and increased risk of cardiovascular diseases. Data on PTDM and risk of microvascular complications are limited. But there is one point that it is quicker in the patients with post-transplant diabetes mellitus, as compared to the general diabetic population. And neuropathy is more commonly found than retinopathy. In people with diabetes who have undergone renal transplantation, diabetic nephropathy can reoccur. And in PTDM patients, de novo diabetic nephropathy occur in 8 out of 81 patients. Pathogenesis of PTDM. Risk factors for PTDM can be categorized as non-modifiable versus modifiable, or generic versus transplant-specific. Knowledge of PTDM risk factor is evolving. Before PCKD was the role of PCKD, polycystic kidney disease, is that some people consider it to be diabetogenic, some people do not. Understanding PTDM risk factor is important to help certify risk and counsel transplant recipient patients, facilitate additional support or consider preemptive modification to attenuate PTDM risk. Post-transplant diabetes mellitus develops in the context of declining insulin secretion and in the presence of insulin resistance. The current consensus is that beta dysfunction is the dominant pathophysiologic defect in early PTDM, while insulin resistance is being the major contributor later in the condition. Early में जो है insulin resistance है और later वो है insulin की decreased secretion है और later IR है. Okay, current understanding of the risk factors for PTDM. What are the non-modifiable age, ethnicity, in which comes the Black, Hispanic, South Asians, family history of diabetes, cause of end-stage renal disease, PCKD, gender, it is found more in males as compared to the female. HLA mismatch, deceased donor kidney, genetics and innate immunity. Previous stress-related hyperglycemia, obesity, metabolic syndrome, please transplant triglyceride levels, the higher they can be found. Two of the infection increase the risk, CMV as well as the hepatitis C. Immunosuppression, in which comes the tacrolimus, cyclosporin, sirolimus, and corticosteroid, basiliximab. In rejection episodes, antihypertensive medication like beta blockers and thiazide diuretics reduce EGFR and hypomagnesemia. Okay, detection of PTDM. Although early post of hyperglycemia can common after renal transplantation may be a risk factor for the subsequent development of PTDM. It is not used as a diagnostic criterion since many cases are transient. Diagnosis should be made in stable period after at least 6 weeks after transplantation. So you have to wait to label the patient as PTDM for at least 6 weeks. जो acute hyperglycemia develop होता है उसको resolve होने देंगे. So what are the parameters with which we can diagnose fasting plasma glucose? It should be greater than 7 millimole, that is 126 mg per dl. As these guidelines were developed by the Association of British Clinical Endocrinologists along with the Renal Association by their consensus guidelines. So majority of the readings are given in the millimoles. So if you just multiply it by 18, you will get the mg per dl values. During the first 4 to 6 weeks after transplantation, FPG alone is of low value to detect hyperglycemia. But despite these limitations, people with high FPG fasting plasma glucose values have poorer outcome in graft and patient survival. 2-hour plasma glucose, this is the gold standard. OGTT is widely accepted as the gold standard for diagnosis of PTDM and remains the diagnostic test of choice in most PTDM guidelines. In these, the values should be, fasting should be greater than 7 millimoles, and 2 hours after the glucose challenge, it should be greater than 11.1 millimole per liter. What are the disadvantages of this test? Poor reproducibility and logistical obstacles. So everybody cannot have this, or the environment might not be that much good for everyone. So glycated hemoglobin, falsely high value can be found in acidosis and iron deficiency anemia. Falsely low value can be found in 4 conditions like blood loss, blood transfusion, shortened erythrocyte survival time, and erythropoietin use. During the first year after kidney transplantation, anemia may be present in up to 50% of the patients. HbA1c is of poor diagnostic value in the first 3 months due to anemia. First 3 months में ये बहुत poor result देता है. Anemia, HbA1c measurements may therefore be considered in stable kidney transplantation after the detection of transplant-associated hyperglycemia and PTDM beyond 3 months after transplantation, ideally in combination with FPG. इन दोनों टेस्ट को फास्टिंग को और HbA1c को दोनों कंबाइन करके फिर आप लेबल कर सकते हो पेशेंट को as having PTDM, but after 3 months. CGM devices offer the ability to obtain glucose profiles over days and weeks and aid understanding of the post-transplant hyperglycemia. CGM monitoring has shown that people with type 2 demonstrate higher glycemic variability than people with PTDM and detects hyperglycemic episodes that would have remained undetected by routine lab testing. So the other measure of glycemia which we have are the fructosamine and glycated albumin. Fructosamine correlates with the glycemic contour during the previous 1 to 3 weeks, used in situation where A1C is unreliable. Management of PTDM. The management can be divided in the acute management of hyperglycemia and long-term management, usually around 3 months post-transplantation. So this is a very important slide. First of all, in the pre-op period, what should we do? Establish risk vectors for diabetes, like obesity, family history, previous GDM history, high ethnic groups like Asians, and glucocorticoid therapy. Monitor FPG and A1C ideally 6 monthly. And these people, those having FPG 6 to 1, 6.1 to 6.9, or A1C 6.1 to 6.4%, they are labeled as high risk. In these people, we should monitor ideally every 6 monthly. If high risk, what should we do? Advise weight loss, increase exercise, and improve diet and smoking cessation. If A1C greater than 6.5% or FPG greater than 126 on 2 occasions, diagnose the patient to have diabetes and put on standard diabetes pathway. Pre-op अगर ये दो मिल जाते हैं तो जो normal type 2 diabetes है हम वो label कर देंगे. Immediately post-op, monitor after CBG reading. If CBG persistently greater than 11, consider therapy. If CBG from 11 to 13.9, patient is eating and clinically well, consider oral hypoglycemic therapy. Like metformin, if the EGFR allows, it should be at least greater than 30. Or sulfonylureas or DPP4 inhibitors, they may be used singly or in combination. If CBG is greater than 14, that is around about 250, so then on 2 occasions, then we should use insulin in this case. If clinically unstable, insulin can further be used either IV or subcutaneously. Agar unstable hai or the patient does not eat, so then what should we do? We should give IV variable rate IV insulin infusion with IV 5% dextrose. If clinically stable and eating commence, subcutaneous NPH insulin 10 units and repeatedly titrate. Consider adding metformin if no contraindication. Our target CBG should be, capillary blood glucose should be 4 to 12 millimole per liter. Refer for dietetic advice to reduce glycemic excursion. Refer for education regarding insulin therapy and CBG monitoring, and undergo regular follow-up by a healthcare professional with expertise in diabetes management. Ensure that primary care are aware of the diagnosis after post-transplant hyperglycemia. Okay, up to 6 weeks post-transplantation. Regular review with the aim to reduce glucocorticoid dose, stabilize immunosuppression, and consider conversion to less diabetogenic cancelionir inhibitors like cyclosporin, if no signs of rejection and stable graft function. तो आहिस्ता आहिस्ता आपके जो ग्लूकोकॉर्टिकॉइड्स है जो हाई डायबिटोजेनिक CNIs है आप उनको रिड्यूस करते जाएं और ये पहला काम करना है. सेकंड इज रिड्यूस ओरल हाइपोग्लाइसेमिक थेरेपी और इंसुलिन इफ पॉसिबल. इंश्योर डाइट एंड लाइफस्टाइल चेंजेस आर ऑप्टिमाइज एट 6 वीक्स. कंसिडर OGTT इफ प्रैक्टिकल. During OGTT, if fasting plasma glucose is greater than 7 or 2 hours plasma glucose is greater than 11.1, diagnose PTDM and treat as below. PTDM diagnose किया तो फिर हम ऐसे treat करेंगे. If this line, if hyperglycemia resolve, that is CBG less than 11 of anti-hyperglycemic therapy, screen for PTDM with OGTT if possible. If not, request A1C and fasting plasma glucose. If A1C greater than 6.5% or FPG greater than 126 on 2 occasions, diagnose PTDM. Ensure patient, this pathway we follow for PTDM patient. Ensure patient and their primary health care team are informed of the diagnosis, and diagnosis is coded on the patient electronic care record. Refer patient for structural education and regular screening of the eyes, feet, kidney, BP, weight, smoking status, and lipid. Just as in our normal type 2 patients, the same things, screen for the complications and other things. Okay. Manage cardiovascular risk factors, individualize glycemic targets according to patient preference and comorbidities. Drugs such as metformin, gliptins, GLP-1 analogs, insulin can all be used safely post-transplantation. Avoid pioglitazone and sexagliptin in heart failure. Seek specialist advice when considering SGLT2 inhibitors, because there are two concerns mainly with this euglycemic decay and the risk of infection. So specialists should always be involved in starting these SGLT2 inhibitors. If A1C less than 6 and FPG is less than 110, PTDM is not diagnosed and hyperglycemia is resolved. In these patients, we should check A1C and FBG every 12 monthly and then annually. If A1C is 42 to 47 millimole, that is 6.6 to 6.4, and FBG is 6.1 to 6.9, patient is at risk of developing PTDM. Then in these patients, we should monitor A1C and FBG every 6 monthly. And we should also offer, because they are high risk, we should also offer them the lifestyle advice. Okay. As we discussed, that it is divided into two. One is the early and second is the long term. So early post of hyperglycemia is associated with poor outcomes, including risk for long-term PTDM, rejection, infection, delayed graft function, graft loss, and death. We should always include DKA and HHS, the hyperglycemic emergencies. Significant hyperglycemia that is greater than 15 millimole per liter should be managed actively with sub-Q insulin if patient is eating and drinking, or variable rate IV insulin infusion, IV fluid, and hourly blood glucose monitoring. Lower level may be managed with oral hypoglycemic agents. No evidence to support very tight glycemic controls. Even some studies have suggested that it might be injurious to the patients if we very tightly control. So once the patient is stabilized, and conversion from IV to sub-Q insulin should be undertaken, usually to a once daily NPH, preferably given in the morning with additional prandial insulin as needed. What should be the glycemic targets? Studies have suggested that poor graft outcome with poor glucose control. Targets are those which are the target in type 2, they should be kept the same. The ADA suggests that it should be around 7. But if the patient is having some comorbidities, then we can relax the target to 7 to 7.5, as suggested by the KDIGO. Glucose lowering therapies in PTDM. Diet and lifestyle should be first base management. Higher weight pre-transplant is a risk factor for PTDM and should be target for prevention. Intensive versus standard dietary intervention. So as we all know that after post-transplantation there is a lot of weight gain. So those people who are given the intensive lifestyle dietary intervention, they just have 5 kg weight gain, while in the standard group the weight gain was up to 12 kg. Mediterranean diet is associated with lower PTDM risk. So oral hypoglycemic metformin is the first line treatment for type 2 in many guidelines and has been suggested as the potential first line agent for treatment of PTDM if renal function allows with appropriate dose adjustment, reduced to 500 twice daily in EGFR less than 45 and stopped if EGFR less than 30. Sulfonylureas commonly used in people with diabetes because of rapid efficacy and ease of administration, useful in early post-transplant period, balanced with risk of hypoglycemia, particularly when immunosuppressive regimens are being titrated. Thiazolidinediones, safe and effective. They can lower the A1C by 1.4% and reduce dose of insulin. They can also reduce the carotid intima media thickness, and they can be used for liver steatosis post liver transplant. Adverse effects are the fluid retention, weight gain, and increased fracture risk. DPP-4 inhibitors safe, but they are having modest efficacy, approximately up to 1% reduction in A1C with no effect on EGFR. GLP-1 analogs increasingly used in CKD, largest reported cohort in solid organ transplantation with dulaglutide showed a mean weight reduction of at the 2 years of 5 kg and insulin dose reduction of about 6 units. SGLT2 inhibitors, significant clinical evidence for cardio and renal protection in the non-renal settings. But in PTDM patient, the data is limited for this cardio and renal protection. Potential side effects like genitourinary infection and euglycemic decay are a concern. Modest reduction in A1C of 0.2% was seen with reduced weight and no difference in adverse events. Insulin. Early post of hyperglycemia may be managed with once daily NPH. Long-term standard regimens like basal insulin, twice weekly fixed mixtures, and basal bolus may be used. Management of cardiovascular risk factors in people with PTDM. CVD remains a significant problem after solid organ transplantation. Smoking, high risk of allograft failure as well as the increased risk of PTDM. This lipidemia category suggests the statin therapy should be given for all renal transplantation, aiming for a target LDL of less than 100. Hypertension, as in the normal scenario for that ARBs, they are not that much good, but CCBs, calcium channel blockers, have shown benefits in hypertension post-transplantation. A target of BP of 130 over 80 milligram of mercury, which concords with the target of 130/80 in people with diabetic kidney disease. Structural diabetes care and screening for diabetes complication. Lower rate of microvascular complication in PTDM, but the progression may be accelerated, justifying regular surveillance. ये आम लोगों में जो माइक्रो वास्कुलर कॉम्प्लिकेशंस होता है, दे टेक फ्रॉम 5 to 10 years, बट इन लोगों में 1.8 years या 2 years तक इतनी जल्दी डेवलप होता है. So this justifies that they should be screened regularly. PTDM should therefore be registered in a primary care diabetes register, receive standard screening and management within primary care. Cross liaison with the transplant team, however, will be required when additional therapy for glucose and cardiovascular risk factor is warranted. Modification of immunosuppression to prevent or treat PTDM. हम कैसे मॉडिफाई कर सकते हैं कि या वो होने ही ना दें, अगर हो जाए तो उसको हम ट्रीट कर लें. Contemporary guidance advocates choosing immunosuppression to prolong patient or graft survival rather than prevention of immunity. प्राइमरी ऑब्जेक्ट को नहीं बोलना, सबसे पहले पेशेंट या ग्राफ ही को करना है, बाद में अगर डेवलप होता है तो हम कंसिडर कर लेंगे. तो अगर शुरू में ज़रूरत पड़ती है हाई डायबिटोजेनिक उनकी, तो हम रोकते नहीं है उस चीज़ को. Immunosuppression should be personalized to each patient for stratified risk versus benefit. Commonly used immunosuppression and their diabetogenic risk. सबसे ज़्यादा रिस्क जो है कार्टिकोस्टेरॉइड्स प्लस टेक्रोलिमस, इन दो का सबसे ज़्यादा है. फिर साइक्लोस्पोरिन एंड एम्टोर इनहिबिटर्स, जिसमें एवरोलिमस और साइरोलिमस ये हैं, स्लाइटली इंक्रीज करते हैं रिस्क को पीटीडीएम के. एमएमएफ एंड एजाथायोप्रिन, दे हैव नो इफेक्ट. बिलेटासेफ्ट का क्वेश्चनेबल इफेक्ट है कि इट स्लाइटली डिक्रीजेस, और बेसिलिक्जिमैब जो कि CD25 इनहिबिटर है, आगे हम देख लेंगे कि स्लाइटली इंक्रीज करता है. फ्यू स्लाइड्स. Corticosteroids, there is debate on the risk versus benefit of corticosteroid sparing regimen post-transplantation. Some RTDs show no effect of steroid sparing regimen on PTDM incidence, while others have shown reduced PTDM. इसकी वजह यह है कि जो डायबिटोजेनिक आप CNIs वगैरह देते हो, तो उसकी वजह से वो स्टेरॉइड स्पेयरिंग का इफेक्ट इतना ज़्यादा नहीं होता. स्टेरॉइड स्पेयरिंग यही होता है कि आप एब्रप्टली स्टॉप कर देते हो या बहुत शॉर्ट ड्यूरेशन में उसको स्टॉप करते हो. Two recent RCTs like Harmony and Advance both showed reduced PTDM with steroid sparing regimen with no increase in rejection. CNIs increased risk of PTDM with tacrolimus showing the greater diabetogenic risk than cyclosporine. The author suggests tacrolimus to cyclosporine conversion in people with inadequately controlled PTDM after the early phase post-transplantation may be considered. Early phase गुजर जाए, फिर आप tacrolimus to cyclo consider कर सकते हो. CNI sparing is further strategy to reduce the risk of PTDM. mTOR inhibitors, everolimus, cyclolimus, उनमें कोई difference नहीं है. In RCT including 613 renal transplant patients showed that everolimus plus low dose tacrolimus facilitate reduced CNI exposure while achieving good renal function, low graft loss with similar incidence of hyperglycemia at 12 months. Other agents में हमारे पास biletacept blocks CTLA4 leading to selective blockade of T cell activation, reduced incidence of PTDM compared to cyclosporine and tacrolimus. Basiliclimab, which is monoclonal antibody to CD25, observational suggest association with PTDM, while meta-analysis does not. Prevention of PTDM, lifestyle intervention, जिसमें आप वेट लॉस एडवाइस कर सकते हो. सेकंड ये है कि फार्माकोलॉजिकल इंटरवेंशन में जो स्टडीज अभी प्लान्ड है कि DPP4 और मेटफॉर्मिन की कॉम्बो को यूज करते हैं फॉर द प्रिवेंशन ऑफ PTDM. इंटेंसिव एंड अर्ली बेसल इंसुलिन थेरेपी वर्सेस स्टैंडर्ड केयर लोवर्ड PTDM रिस्क एट 12 months by 73%, possibly due to beta cell protection from stress hyperglycemia. तो आप इंसुलिन के साथ अच्छा कंट्रोल कर लो, इससे भी स्ट्रेस हाइपरग्लाइसीमिया से आप उसको वो कर सकते हो, प्रिवेंट. हेप्सी को ट्रीट कर लें बिफोर, तो उससे भी PTDM कम हो जाएगा. चॉइस ऑफ इम्यूनोसप्रेसिव रेजिमेंट जो कि डिस्कस हुआ है. PTDM consideration, just a few slides. In non-renal setting, नॉन रीनल सेटिंग में क्या हमारे पास लिवर है, जो दूसरे सॉलिड ऑर्गन्स हैं और लंग्स हैं, उसमें बताया है सबसे ज़्यादा जो नॉन रीनल सेटिंग पीटीडीएम आफ्टर लिवर ट्रांसप्लांटेशन अप टू 40%। इसके दो कॉजेज बताए हैं उन्होंने कि एक नेश प्लस एचसीवी। नेश जिन लोगों में शुरू में नेश होता है उसकी वजह से फाइब्रोसिस और वो लिवर ट्रांसप्लांट पे चले जाते हैं, या जिनको हेपेटाइटिस सी हो और फिर आप लिवर ट्रांसप्लांट करते हो, इनमें बहुत ज़्यादा है। इंक्रीज मोर्टेलिटी एंड सीवीडी एसोसिएटेड विद पीटीडीएम आफ्टर लिवर ट्रांसप्लांटेशन, वेट गेन कॉमन एंड शुड बी मिटिगेटेड, रीनल इम्पेयरमेंट एंड एनीमिया कॉमन, सो द सेम प्रिकॉशन इफ द A1C स्टिल अप्लाई। मैनेजमेंट ऑफ डायबिटीज इन द सेटिंग ऑफ लिवर इम्पेयरमेंट कैन बी चैलेंजिंग। क्यों? बिकॉज मेजॉरिटी ऑफ द ड्रग्स जो हैं वो लिवर के थ्रू मेटाबोलाइज होते हैं, तो उस वजह से मसले मसाइल हो सकते हैं। पीटीडीएम आफ्टर हार्ट ट्रांसप्लांटेशन, okay. PTDM rates of 25 to 28%. Okay, let's come to the last slide. This is conclusion. PTDM is an important contributor to morbidity and mortality after solid organ transplantation. Management should be by a multidisciplinary team of specialists. Studies in these areas have been short-term, बहुत लिमिटेड डेटा है, शॉर्ट टर्म, अंडर पावर्ड एंड यू surrogate outcome. As a result, large areas of uncertainty exist, and further research is warranted to develop evidence-based care for solid organ transplant recipient with or at risk of diabetes. And thank you for your patient listening.
Thank you so much for a very nice talk. And I'll start with the question answers. And first question I'll take from you so that you are on the stage. Okay. So the question is, why fasting blood sugar level is not good in initial days after transplant?
मैम इट वेरीज फ्रॉम डे टू डे, बहुत ज़्यादा फ्लक्चुएशन होती है, तो स्टेबिलिटी नहीं रहती है, इस वजह से एफपीजी को इतना ज़्यादा प्रेफर नहीं करते। मगर स्टिल जिन लोगों की एफपीजी ज़्यादा होती है उसका एसोसिएट किया गया है कि लॉन्ग टर्म में और इसके साथ एसोसिएटेड होते हैं।
Thank you so much, and thank you for being here. Our next question is from Dr. Shweb. Is he here? So, Dr. Shweb, the question is, what is the role of vitamin E and selenium in diabetic neuropathy? Do they help?
Thank you very much. I looked at the evidence regarding I looked at the evidence regarding different supplements, and there was a really long list. So you can ask this question about selenium, about vitamin E, about carnitine, about calcium. So to be honest, I haven't looked into detail about these supplements, about selenium and vitamin E, and I don't think I will be able to answer that at the moment.
Thank you so much. Okay, so Dr. Adnan, are you here with us? Right, the question is, which percentage of patients never recover from HB excess suppression?
I am not sure about the exact figures, but I think around 10 to 20% they have they fail to recover, or they'll be on they should be on the steroids for the longer time, and we need to keep assessing with the clinically as well as with the serial monitoring.
Thank you. Dr. Maliha, there's a question for you as well. Do we need to treat anti-TPO with normal thyroid function tests in someone who is going for IVF or ICSI?
Thank you, Dr. Niba. That's a very good question. Now here, the thing is individualization of treatment, and it is a physician choice according to the characteristics of the patient. Now, this patient undergoing for IVF, anti-TPO, and depends if the patient has a long history of infertility, recurrent miscarriages, then it can be treated.
Thank you, Dr. Malia. We have a last question. Dr. Mati wants to add something? Okay, please give the mic to Dr. Mati.
Okay, so thank you so much. I would say that this was in 2017 ATA, what Dr. Malia answered. We used to consider it treating when there is anti-TPO positive, but the TSH is in the normal range. But then tablet trial came, so after that it is clear that there is no evidence of it. And we should explain this to the patient that there is actually no benefit of it. We may be giving it, but we have to explain to the patient, because sometimes the patient will think, Doc Saab ne thyroxine de diya, फिर भी miscarriage हुआ, at that point of time, they will blame us. So I think we should have a good communication with the doctor as well, जो refer करे, and with the patient as well. Thank you.
Great point, Dr. Mati. We have a last question from Dr. Shweb. B12 replacement, oral versus IV, versus active form of B12, the preference according to the guidelines.
So the guidelines are that if you are replacing B12 with anemia, you can give IM. But if you're just treating it for nephropathy, normally it's all the trials have used the 500 microgram once a day. So if you follow the trials, you'll have to give it oral. But I personally feel that if there's anemia as well, and if there is a long-term maybe dyspepsia issue or absorption issue, if you're thinking about that, then maybe IM is also an option.
Yeah, thank you. That makes sense. So, so thank you so much. Towards the
one more question, please.
Sure, of course. Your question is from?
I want to ask that is there any guideline related to patients taking inhaled corticosteroids when they should be screened for heterogenic Cushing?
Dr. Adnan, please.
Well, as I mentioned that basically this problem we are dealing with is a multi-speciality, like basically either the patient from the rheumatology or the pulmonology coming up. The point you mentioned regarding the inhaled steroids, if the patient like taking the inhaled steroids, and it depends like if he's using the spacer device, because that reduces the chances of the oral swallowing. So if the patient like having the features of the Cushingoids, having the features of the adrenal insufficiency, then again clinically you should keep in mind to assess the patient for the adrenal insufficiency. But again, mostly in our practices, like the pulmonologists, they usually don't like there's no set guidelines like after 5 weeks of inhaled steroids you need to assess for the adrenal insufficiency. So again, it's a matter of the clinical judgment, and the coordination, the liaison should be there between the specialties.
Thank you, Dr. Adnan. Thank you, everybody. We have reached actually to the end of a very, excellent midsummer conference, and I think everybody should be proud of themselves for being here, for contributing in every way possible. Before the end of this session, I'd like to give the podium to Dr. Tahir.